and good morning or good afternoon, good evening from wherever it is that you are calling in from. We're happy to have you. So welcome to the Data for Impact webinar on using routine data in economic evaluation. I'm Jessica Farringer. I'm the Technical Director of Data for Impact. And for those unfamiliar with Data for Impact, or DFRI for short, we are an Associate Award of Measure Evaluation. That's a name that's been around longer. You may be more familiar with them or with that project. And we continue Measure's long legacy of building evidence to improve health systems and programs. D4I supports countries to generate and use high quality data to improve their programs, policies, and ultimately health outcomes. We also strengthen the technical and organizational capacity of local partners to collect, analyze, and use data. This is the first webinar in a series sharing lessons learned and practical suggestions on using routine and other existing data for evaluation and research. The second webinar in this series will be during the first week in December. We're still finalizing that date. But that webinar will focus on imputing missing data when working with routine data for evaluation. So you can be on the lookout for an email announcement from us if you're on our listserv, or look on our website for announcements on the date on that. So we created this webinar series with the goal of providing practical information that helps global health evaluators and researchers to make better use of routine and other secondary data. Evaluators and researchers have often avoided use of such data, preferring to use things such as standalone surveys that are designed specifically to meet your evaluation or research objectives. But in light of the potential cost and time savings, I say potential because it's not always a cost and time savings, but in light of the potential cost and time savings compared to collecting primary data, it's important to consider routine and other existing data when you're designing your evaluation or research project. Routine and other existing data do come with their own set of challenges that we need to consider and address. And we hope that today's session sheds light on these challenges and other factors related specifically to using routine data for economic evaluations. And we hope that it helps to inform your work moving forward. So with that background, I want to introduce you to today's speaker, Anna Krivelyova. Anna is a principal economist at ICF. She leads cost analysis and economic evaluations of health programs and interventions in areas like HIV, antimicrobial resistance, laboratory strengthening, vector control, and mental health, probably among other things. We all wear many hats, particularly these days. So Anya, I will turn things over to you. And I should also note the slides will be made available after the webinar, as well as a recording. So we will be sending out an email to all registered, everyone who's registered that has a link to the slides and to the webinar. Thank you, Anya.
Hi, everybody. I'm just going to say hi like this on video, then I'm going to turn it off so that we don't eat into the bandwidth. Hi, everybody. Jessica, thanks so much for the introductions. Everyone, thank you very much for joining and your interest in this topic. I hope to meet your expectations, and I'm looking forward to your questions. I also hope we have a lively discussion in the chat. Again, the questions that will be in the Q&A, I'm going to try to answer towards the end of this of the webinar. All right. Jessica, I think we can go to the next slide. As a brief overview of what we will talk about today, we will discuss some general reasons for why cost measurement is important. I'm assuming since so many of you joined this webinar and decided to join this webinar, you already have a pretty good idea of why those need to be measured. We will provide a brief overview of the types of evaluation approaches and the types of information you may need for different types of evaluation. And depending on the research question or the program question that you're trying to answer. We will discuss examples of the routine data that can be used to measure costs. And also largely, while we have limited time, and it's a complicated area actually. So while I'm going to give a very basic overview of some of the more theory types things, what I'm really trying to accomplish today is to give a practical examples on what this routine data for economic evaluations for costing looks like. Where do we find it? What you can and really cannot do with just using routine data, and different factors that affect feasibility of actually implementing economic evaluation type studies. So again, there is nearly not enough time to get everybody trained up, and you can, after this 1 hour, you can go ahead and start just collecting the data and analyzing this data. What I'm really trying to accomplish is to give enough flavor here, and enough examples that which will prepare you a little bit better to know what questions do you need to really ask before you before you decide to undertake such data collection or analysis, and kind of what are the limitations and what are the really important feasibility factors to consider. So we're going to have a little bit of theory and then a lot more kind of practical conversation. So another thing I just want to note before we go, I'm going to give quite a lot of examples related to PEPFAR HIV programming. It's just because I've done a lot of work in this area. It's an area which is really close to my heart. At the same time, a lot of what we will be talking about will be applicable across different health interventions, across, and in some sense other development sectors as well, such as nutrition, education, and other areas in which some of us can be touching in our jobs. Okay, next slide, please. So program managers, policymakers, donors normally cannot make fully informed decisions about what's the best way to invest limited resources without having some information on what are the costs of achieving desired outputs and outcomes of this kind of health programs. So measuring costs can support government policy objectives and inform future investment decisions, or help inform discussions with kind of sectoral stakeholders, perhaps with whom you are building more cross-sectorial initiatives. You also often need to know how much is gonna take me to scale up an intervention nationally after a pilot in, say, in one of the regions. Or, what do I actually need to sustain a program after potentially some sort of seed money, or the, is finishing, or the pilot is finishing, or the donor is transitioning out of the country. So there are also questions that are related to efficiencies. What are the main cost drivers of my program or intervention? Can I restructure something so that I can provide the same types of outputs with potentially less resources or less costs? And of course, there is a whole other layer of decision-making related to how really the resources should be allocated across interventions, or even sometimes across sectors, to maximize kind of value for money and returns. I'm not going to list all possible reasons why cost measurement is important. Again, I'm assuming that since you've decided to attend this webinar, you already probably have a pretty good idea of kind of how you're going to use it. Next slide. So this is we're going to spend quite a lot of time on this slide, and it's one of those more theoretical things that we're going to talk about. Quick overview of different types of evaluation. That's what we're going to talk about. So there are 4 types and 4 terms, kind of 4 large buckets that I listed here. There are other types of things, other methodologies, or kind of branches of these methodologies. There is a little bit of, I would say, maybe sometimes disagreement, or some slightly different terms that are used to call different types of economic evaluations. But the ones that I provided here on this slide, it's really probably one of the most common way to kind of classify them. The first thing to mention here among this, we are talking about these four types: cost analysis, cost effectiveness analysis, cost utility analysis, and cost benefit analysis. So the first difference here is that this lonely box in the bottom, which is cost analysis, it's kind of where you only need to measure costs. You really don't care about the outcomes. All you care is costs. The other three, the commonality among all of them is that in addition to measuring costs, you also have to measure effects. Now, then the difference between those three in terms of how they actually measure effects. And we will discuss a little bit about it again, kind of the differences between them, what the definitions are. So again, cost analysis, it's that simple box on the top. We're only going to figure out cost part. However, that doesn't mean it's simple. And sometimes actually doing detailed costing might become much more complicated than doing simple costing and some of those other more progressive type of economic evaluations. Again, just to give it a little bit of the preview, in the rest of this webinar, we will really concentrate on that first box largely. Cost effectiveness analysis. So here, the effects are measured in natural units. And cost effectiveness analysis is really the measurement of the cost to achieve 1 unit of a desired health effect. So here we measure effects in kind of our familiar terms. It might be the decrease in the viral load rates. It might be increase in the exclusive breastfeeding rates. So these are, normally what we're connecting for, the type of data and type of measures that we are already probably using for our outcome evaluations or impact evaluations. So now the thing here, kind of just to note that you can use cost effectiveness analysis when you are really comparing potentially to programs that have the same measurement of the effects. So you cannot compare immunization program to a TB program. You really can just compare apples to apples here. So then moving on to the kind of a to what is called cost utility analysis. Here, the formal definition is that it is focused on the incremental cost to gain 1 quality adjusted life year, which is the QALY, or to avert 1 disability adjusted life year, which is a daily. So both of those, dailies and QALYs, are measures of disease burden on 1 year of life. So here, I'm not going to go too much into QALYs and dailies, but there are various resources and various calculators available to actually calculate what they are. They're not easy to do. You need a lot of data requirements as well to estimate them well. But largely, again, the one thing to note here is that here we can actually compare different health programs of different health kind of intended outcomes. You can, so in this case, you could be comparing, in theory, the immunization program to the TB program. So another kind of I think maybe a little bit more of a fun fact, it's called cost utility analysis because that's how because utility is how economists call happiness or satisfaction. And then you have these utils, which are these mythical little units that can be used to measure your happiness. So health economists actually are a little bit more practical than the rest of the profession. And they decided that it might be a little difficult to explain what utils are to the policymakers, and decided to use dailies and QALYs instead. But in general, it kind of, the logic still is the same. So moving on to the cost benefit analysis. Cost benefit analysis is actually probably the most intuitive and the easiest one to understand, but it's the hardest one to actually do or do well. So in the cost benefit analysis, we still have our costs. We always have the costs, but the effects are measured in monetary terms. And basically what it says, I'm going to spend this much money on a program or an intervention, and I gain that much money. Which one is bigger? Again, it's a very oversimplified way to talk about it, but the logic is behind it is what it is. Here, I mean, I'm sure that a lot of you are probably wondering, right? Okay, well, how do I actually do that? How do I say, well, the 10% improvement in the viral loads translates into, I don't know, $200? And if you're wondering that, you're right in thinking about that, because it is actually quite difficult to do. And that's why those studies are not really done very commonly. So the way the approach is behind those behind the measurement and monetizing those effects, the health effects that you see from the programs, largely are using economic type indicators that are related to employment or related to salaries or related to tax base. So the logic, again, a little bit oversimplifying, but the logic here is that I got health services. I'm not sick anymore. Because I'm not sick, I can be now working. And I'm working, I'm making money, I'm paying taxes, and that's kind of how it all translates into money and dollars or whatever currency you're using. So that's the logic behind the cost benefit analysis. Next slide, please. So here there is a couple of things to note. Cost utility and cost benefit analysis, and to some extent cost, and sometimes cost outcome analysis, cost effectiveness analysis as well, normally requires quite a long-term follow-up period. It potentially requires some mathematical modeling. It requires, beyond the routine data that might be collected as part of your program implementation, it often requires a lot of other epidemiological data, population level demographic data, some sort of employment statistics, salary levels, and things, not salary levels of the people that work on the program, but something at the macroeconomic level. So they can be, so in reality, really what you probably need as an underlying base for all of those analysis is some sort of impact evaluation. And I'm not going to talk about it because I'm sure that it's probably a separate topic of other webinars that you've been attending. Now, the cost analysis, this our lonely little top box from the previous slide. It doesn't require necessarily some of that long-term type of modeling, but it's not necessarily, again, repeat myself, it's not necessarily simpler. And it really depends on many, many factors. And that's what we're going to kind of talk a little bit as we progress through this webinar. Next slide, please. Okay, so on this slide, we see some examples of typical questions that cost analysis can answer. You will also see, finally, words here, routine data on this slide, so we haven't heard them before. I'm going to use this little green, yellow, and red bar that you see a couple of other times throughout these slides. And this is really kind of my qualitative measure of feasibility, right? And what you can get out of routine data and what, if you just use routine data exclusively versus where you really need to supplement it with something else. So the other thing I want to make clear, so then when we're talking about routine data, and I think Jessica alluded to that a little bit in the beginning, I'm also definitely not talking about some nice data set that you can kind of just crunch and analyze. I'm going to be talking about various sources. Sometimes it's on paper, sometimes it's electronic, but you can't really use it in a format that it is in. So we're not talking about nice, pretty data sets necessarily. back to the research questions that you see. The range here is, can be, what is the total cost of the program or intervention? This is the types of things sometimes you can see on the, costing national action plan or, national accounts or, so it's a very large kind of a sometimes macro level type of assessment that doesn't necessarily give you huge amount of detail of what's kind of going on underneath all of it. As we progressively move down, these questions, the questions themselves don't necessarily seem to be much more complicated, but the data that you need for those to answer those questions is becoming more and more complicated because we start needing more detail. We start needing to understand that, okay, not just how much it cost, but on what did you spend it? It starts, or how did you spend it? Or are there differences between different client groups or patient groups in terms of how much you need? So all of that, again, progressively is complicating things. And as a result, it's also kind of decreasing the probability that you can only rely on the routine data to make those estimations. Next slide. So when you're designing any study, for any of you that had to design any kind of outcome study or anything else, you clearly have to kind of determine what is your design. In designing economic evaluations, there are some things here which are kind of common to a lot of other evaluations that you might have done. What is the time period? What's the population of focus? Are we doing prospective study or retrospective study? However, there are also a few things here which are more specific to economic evaluations. One of them, this perspective, and we're going to talk a little bit more about it later in a little more detail. There is also something that you need to consider as well, which costs you're going to be including and which are going to be excluding. And that decision, sometimes it's more theoretical decision and determined on kind of your research question is going to be dictating that. But sometimes it's also a practicality issue. So we've had, sometimes you start out and say, well, I'm going to measure those costs. But when you, in reality, start and try to get the data, you can't. So then you're right, well, it was a limitation, we dropped that group. So this is just, again, this is something that to keep in mind, but these are the things that you would need to be deciding on before you kind of embark on this journey of conducting cost analysis. Next slide. Okay, so back to this analysis perspective. So pretty much what that is that from whose perspective are you measuring costs? And there are other types of perspective or something in between the three that I listed here, but generally these are kind of the common ones. So you could be measuring costs from the program perspective. Now, this doesn't necessarily mean there's just one payer and it's all, under one, kind of pot of money that came from some sort of a grant. You can have, and we're actually going to talk about examples where we have a lot of different payers or a lot of different people that are providing resource or entities that are providing resources for the program. And these things would cover kind of normal types of things that a lot of us see in our even financial reporting when we have to do grant reporting. Personnel, supplies, equipment, drugs, transportation, travel, training. These are the things that we are trying to kind of assess. So the other, so the next one is the client or the patient perspective. It's a very different perspective, right? Because the client, how much does it cost for the client to participate in the program? You can have kind of a more direct thing, such as user fees, to receive a test, for example. You might have, again, more direct cost because the patient or the client actually has to travel to the health facility and incur costs to pay for the bus or to pay for the hotel if they have to travel and they have to stay overnight. But then you also have, kind of what is called opportunity costs. And that is, how much time the client or the patient has to invest in receiving services. If they have to travel to the clinic every day, even if they walk and don't have to pay for the bus ticket, that eats into their time, and they can use that for other purposes. So, and then there's the societal perspective. The societal perspective, again, this lost production taxes little bullet point might look familiar. It's actually largely used when you are attempting to do cost benefit analysis, about which we talked a few minutes back. Um, it is something that is, not super probably practical to attempt. And again, we're not going to really talk about that. So I am going to concentrate today about this program type of perspective largely when we talk about cost analysis. It is something that normally you can get from out of the routine data. And actually, interestingly enough, the routine data is normally the primary source for such studies. Um, the For the client patient type of perspective, you potentially can get something a little bit in your routine data that would allow you to measure at least some components of those costs, but it's not highly likely. And for that is something that really largely normally requires some sort of a survey. However, again, not to say that it's not an important factor, it's a very important issue. User fees, a lot of you know kind of some of the issues that are happening right now, especially in some of the Western African countries, in terms of trying to eliminate user fees that could become big barriers. But again, this is not something that easily can be used, can be assessed using routine data. Next slide. Okay, so I am going to start maybe a little bit of on a negative, but it's going to be, I just want you to be aware, why am I kind of honing in on certain things on the following slides. Now, to measure costs, you actually need routine data. But the problem is that this routine data, it exists, but it often is in many different places, many different formats, and it's not an easy thing just to kind of to agglomerate together into some comprehensive picture. The other thing that makes it difficult with measuring costs is that the resources sometimes are used by one entity, but somebody else is paying for it. So you don't have this one kind of a confined entity that has all this information and everything matches up. So the other thing here is that depending on the level of detail, but even for kind of minimal level of detail in measuring costs, you really need to have a very detailed understanding of implementation and service delivery models. If you don't have that, you're not going to be able to kind of capture all of these different components that you need to capture. Other thing is the benchmarks. They rarely exist. It's very, very difficult to take some sort of a cost estimate from one country and say, okay, well, that's what I'm just going to assume for my country. Even if you use correct exchange rates and things like that, contextually, things are just too different. The other thing, and even within a country, sometimes you cannot compare directly one facility to another in terms of costs, because again, contextually, it's a lot of drivers, in kind of invisible drivers, that may lead to very different cost structures. Next slide. Okay, so this is a picture, as you can see. Here, we actually have, is an example of a kind of a relatively typical HIV treatment program. So again, this is something that would be very typical for kind of perhaps a PEPFAR supported program in a country. So you have this facility site. So that's where the patients received actually services, right? So they would come in, they will be seen by the nurse, they will get tested, they will be given drugs, and there will be some efforts to do retention and adherence types of counseling. And that's where kind of the most visible part of service provision is happening. But if you think about it, what goes in there, right? The drugs somehow have to make it from the warehouse to the facility. First, they're stored there. There is a cost incurred there. Then there is potentially a truck that takes them from the warehouse to the facility. You might have some above site structures. You might have technical assistance provision. You might have like a subnational regional office that comes to the site, provides some training, provides some sort of supervision visits. That's another cost, right? Because that's what it takes to actually, do the service delivery. Then you have a situation where potentially the lab is not in the same facility. So you are drawing blood, you're getting samples from the patient in the facility, but then those samples have to make it into a separate laboratory where it has to get tested, another cost, and then come back somehow back to the facility to be communicated to the client. Then in certain cases, you also kind of have a community service component. In one facility, you might have adherence done by a nurse in the facility, but in another facility that is also providing treatment, HIV treatment. So it's the same name, but the adherence is done by community healthcare workers. So again, that will be another cost center there. So you can hopefully see how it's all kind of building up and building up and building up. Jessica, next slide, please. So here again, it's the same picture that we've had before. And now we start kind of maybe looking a little bit more carefully at this picture. What do we see? So clearly we see the doctor on a nurse. This is our personnel costs, right? That staff member has to spend time doing various different things. And sometimes it's not just the clinical care. They might be doing M&E and lots of other stuff. We see equipment. So there is a cupboard where the drugs are kept. There is a stethoscope. There's, things here. We see drugs. You see those little bottles. So that's a resource. So that's going to be used. We see supplies. We see gloves. So these are supplies. These are our consumables, right? We see gloves. We see something that's probably being used to draw blood. And we also see infrastructure actually here. So this is pointing to this blue wall. There is a building, right? So all of that is taking place in some sort of a building where there is, we need to pay for utilities. There might be some contracted services like guards or cleaning services that come in. and then there's all these other kind of cost components that are coming in not from the facility, but they need to be incurred in order for that service to actually happen. Next slide, please. So here another kind of, again, the level of complication here is that there are different entities who are paying for different things. So I'm not going to go over excruciating detail here, but just to give you an idea, every type of component might be coming from different groups. Some components are provided or paid for by multiple entities. So where is all this data going to be, right? From whom are you getting invoices? So all of that has to be mapped out before you kind of to actually collect the data. Next slide. So now what do we actually need, right? So now we see some of these simple formulas, right? I mean, we can think about it if we have to make a cake or cook or something like that, right? We need a quantity of something, there is a unit cost of that something, and pretty much what is my total cost is one multiplied by the other, right? So if we need to use, 10 pills and the cost per pill is $1, we need $10. So we have these quantities and we have these unit costs. What we also have is these allocations. It's not showing up in the formula, but we'll talk about it kind of as we go along. So the sources of routine data that exists for your cost studies will always differ depending on this component. You might have quantities sitting in one database or in one office, unit cost in another one, and some sort of information on how you allocate it, what's the right way to allocate it is in a completely different database or a completely different entity again. But what also is true is that for each type of component here, for quantities, for prices, for allocations, you might have multiple sources of data. And you also need to kind of figure out, well, can I triangulate them and or is there one source that's better than the other? Next slide. Okay. So here, let's just kind of go quickly. So drugs, right? So let's say we have some sort of a treatment program where the patients come to the clinic, they need to receive some sort of medications. So the quantity, how much drugs will actually used or dispensed, that might be coming out from electronic health records. That's great if we have something like, you know, DHS2 system. For every patient we knew, they came on this date, they got this many pills, then they came again, they got this many pills. This is really great. It doesn't always, is not always there, right? You can have, and that's something that you will find on the facility level. You might have pharmacy dispensing records. So that's not necessarily going to be at the patient level, but every month the pharmacy is going to have a record and say, okay, that's how many pills I dispensed in total this month. Then you might have some sort of stock registers or cards, again, at the facility level. You might have invoices at the facility level, but then you might also have some of this information on kind of the other side of it, right? You might have warehouse that has orders and delivery logs to specific facilities. So, and that's another kind of a place where some of that information might be sitting. Then you have prices. Sometimes you're going to have a source of data that has both. Here is what I used and here is how much it cost. Sometimes you're going to have those two things sitting in separate databases. Sometimes there will be some country level procurement types of lists or standard kind of market prices. Sometimes those procurement prices might have from some sort of a global source or funder procurement lists, so which would give some sort of average price for a particular drug or particular supply. Next slide. So here, this is actually real life examples of what we have been collecting as part of some of the cost studies that we have done. Actually, I think with an example with our colleagues from US Centers for Disease Control and Prevention for PEPFAR projects. So this handwritten thing that you see, this is an actual picture of the law of a bin cards or logs from the facility of this is how many drugs we had stock, that's how many we used next day, that's how many we signed out. So that's what this data might look like. Then you have this kind of in the opposite corner, you have something which looks like an Excel file. It looks great, right? It looks nice. We have quantity, we have price, we have everything. And then you have something in between. This is our dispensing data, something that's come from the facility. There may be some information on how many things we received from the facility side. So now this data, if you're going to look at these 4 pictures, you are naturally going to say, okay, well, if I have something like that in that Excel file, that's what I'm going to use. That's actually not, it's going to be the easiest thing for you to use, but that's not necessarily going to be the most precise thing. And an example here, for example, this particular screenshot from the Excel sheet, it's a data that came from the warehouse. And so they had perfect system, everything was tracked, everything is nice. The problem was, and that's what it was sent for a specific facility. The issue with that was that the facility was kind of a mother facility, which had several satellites. So they would receive these drugs, and then they would send a lot of those drugs into the satellite facility. So if we only look at the mother facility population and think that all of these drugs went to the mother facility, we're going to be hugely overestimating the costs. So that's kind of and so in this particular case, we actually had to look at the dispensing data within the facility and then get the prices from the invoices and combine them too, but then we got a much better measure of quantity, much more better, precise measure of quantity. Next slide. So personnel, this is not easy. So it's not very difficult to get. So you usually will have lists of personnel that your facility in charge will have some sort of a database where these are the people that I employ. A lot of times they will have actual salaries that you might need. Sometimes you might have the staff lists and some sort of grades or the titles or position titles, but you might have to get salary schedules from some sort of central level. But largely that information exists. However, the personnel, and we'll talk a little bit later, I'm running out of time, but I'll try to go fast. It's also one of those very difficult things to allocate correctly. So next slide. So here again, this is an example, here's in our Excel sheet, this is actually really nice data. So we know, for each position, we know who was employed, we know on which dates they were employed, we know what their salary is. On the other little screenshot, it's more of the schedule. So we got average kind of salary information from these types of positions, and then we had to combine it with the, how many nurses did they have, how many, how many doctors they had, et cetera, et cetera, et cetera. So again, when you're capturing personnel, it's important also to get if you don't know, if you cannot get the salaries from the facility or from anywhere else, actual salaries of the personnel, you really need to know a lot about their grade or some sort of because nurse 1 is not the same as nurse 3. The nurse 3 might have a much higher salary than the nurse 1. So the precision there of the estimates will be hugely affected sometimes by the actual experience of the personnel. Next slide. So this is again, I think it's kind of, we've already seen some of these things with the drugs. It's a very similar situation. Equipment sometimes is actually on the harder side to get correctly because it's something that lasts a few years. Sometimes you'll have to go much further back to understand how much was actually spent on some of the equipment. Next slide. These are, again, some real kind of scans. So just to give you an idea, of kind of some of the ways the equipment, utilities, contracted services could be captured. So here you really have more like a purchase level data on the right. So we know what the item was, we know in which year it was bought, we know how much it cost. And then you have something like an invoice or some sort of a system that might be tracking the usage. So again, very, very similar, but you have to kind of, again, here figure out what's your best source of information, what's the most precise source of information. For example, here again, on the Excel sheet, the one thing that might strike you, okay, so there is equipment, there is, some sort of equipment, there's some trucks and blah, blah, blah. The important thing here is actually the data looks nice, but is that all that the program used? Or is everything on the list that actually went to the program that I am investigating? So here, one thing, if you notice, there is something that's called VCT form printing. That's actually a voluntary counseling and testing program. So what here the request was, okay, give us everything that has to do with treatment. So when we see the word VCT, we know, okay, that's actually something that shouldn't be included in this list because that's not the cost that we're trying to assess. So we will have to review it in that way. Next slide. Okay, so this is a little bit more about data management and data I think data quality and data management. When you are collecting these types of data, you're going to have your normal, regular types of issues as you will have with any other study. Sometimes you're gonna you have missing data, 3 months of receipts were missing. So you're missing 3 months of receipts, you only have 9 if you're making an assessment for a year. You're going to have things that illegible writing on something, right? So you can't use that piece, you have to impute it or do something else. So you're going to have this kind of standard issues that we're all experiencing independently of the types of evaluation or routine data that we're trying to use. However, here you also have kind of additional issues. So one of those issues is that you really need to know what resources or what things go into the program. Because if you don't know what you don't know, you will never know what is actually missing, right? So you need to know that to, I don't know, to do a particular test, lab test, these are the reagents that you need. So if you don't see those reagents in the list, you know it's missing, and then you have to go and try to track them down somewhere else. So, and similarly, you have to kind of assess it from the other perspective. Is everything that I received on this list actually relevant for the program for which I'm trying to count the costs? So here, and then this is kind of the last very particular issue, is really about kind of merging prices and quantities, because again, there could be into different sources. Um, and here, it's just like when you're trying to merge people based on from different databases, your patients using some unique ID. You have to be very careful. So the price of the 300 milligram drug is not the same as the price of the 600 milligram. So your description of the item for which you're trying to identify the cost really has to be detailed enough to give you the right price. Red top and gray top tubes. This is an example that I personally made a mistake in because I didn't think it really mattered, right? Is it a red, gray? I thought it was a matter of taste. But in reality, those tubes, they're used for different purposes, and the cost of them is very different depending on the color. So the other thing to keep in mind is in what units we're measuring things. Is it a box of 100 or is it a box of 1000? Right? Again, so all of that has to be somewhere. So when you're scanning the data and you see gloves, you don't know how many gloves it was. So you might need to go and figure that out. You don't know if it was 100 gloves, one glove, or 10,000 gloves. So next slide. Okay. So this is the where we kind of, I want to talk a little bit about these allocations. And I'm sorry, I know I'm running a little bit late, but I think we could, if you guys are available, we could go probably a little bit longer. So the kind of again here, we back to our green and red bar. The problem sometimes is that you can get all these invoices, you can get all these logs and all these data, but it's not always that all of those costs go to what you're trying to cost. So you might have a hospital and they gave you, okay, well, this is all of our use of antibiotics, right? But you only need to figure out which proportion of antibiotics is relevant for your program. And the data, existing routine data, is probably that won't be one of the most problematic issues because it's rarely nicely and cleanly going to tell you, okay, well, this is only for HIV treatment, or this is only for mobile testing, or this is only for this. It's just not captured like that. And the difficulty of that increases given some of those factors that I have here on the screen. And when you have a standalone HIV treatment clinic, pretty much everything that this clinic used is all the costs with all those resources, that's your cost. When you start moving to more integrated services or more integrated types of facilities, or programs which require multiple entry points within a hospital, such as PMTCT, this use of routine data and allocating costs correctly becomes more and more and more complex. And then on the other side, we kind of have these service delivery models in some sense. And the more diversified the service delivery models are, so the more different client types you have and they receive different services, the different service packages, again, that creates a lot more problems and a lot more difficulties in allocating those costs correctly. Next slide. So here, to kind of finish, there are definitely options, but they require kind of, again, potentially additional data sources. Certain things you can actually allocate based on some other measure. So again, in the simplest terms, you might have utilities for the whole hospital. Your HIV clinic or whatever program is is on approximately takes 10% of the total size of the hospital. You're going to take big utility cost, allocate 10% of it to your program. So again, this is kind of a simple scenario. The other it's easy if you can do it with certain things. It's often quite difficult to do with personnel if the personnel are not just exclusively working on your program, but they're supporting multiple programs, doing multiple services. You can't usually use a very good estimate or something out of the air to allocate that. So this is where a lot of times you actually need some sort of a primary data collection to talk to the personnel and understand how much time they spend on this versus that versus that. You can also use some normative assumptions. You have to be extremely careful with that. This is, for example, well, if according to the country guidelines, the patient has to be tested every 6 months, we're going to assume that in a year, this person receives 2 tests, and we're going to multiply it by the average cost of the test, and that's our cost. Sometimes it's possible, but you have to be really, really careful about it and think how realistic is that. So the other thing, sometimes you end up really just excluding certain costs from the analysis because you can't allocate them very well. And unless this is a major cost driver, it is sometimes just easier to say, I know there is this cost, that cost is not substantial, and I'm not going to spend 3 months trying to figure out how much it costs because I know that I'm just not going to be able to allocate it very well. So it's better to exclude it in that case, in certain cases. Next slide. So again, kind of other lessons here, some of the lessons. You really need to understand implementation in service model in order to do it well, especially if you're trying to assess cost in any level of detail. And how complex or heterogeneous your service delivery models are for different types of patients would also have effects on how complicated it is to collect good cost data. You need to kind of you need to have at least some idea of what the major cost drivers will be. So if something like, basic supplies like cotton balls, you're not going to use a lot of them, don't spend 3 months counting them because it's very little payoff from that. Concentrate on doing a better job on something like personnel, something like drugs, in certain cases, laboratory reagents that are much more expensive and better to get that precise. Next slide. Okay. So again, routine data, has to be in some sort of analyzable format. If you, and this is again, just a little bit of a trade-offs that you need to have, because again, if a certain cost component is captured, but it's captured in a really terrible way, but it's not a major cost component, drop it. Again, you need to think, is the reasonable allocation feasible? And that is something that you actually need to think really, really well about before you start a study. In certain cases, prospective evaluation or some component of prospective data collection might actually be easier. You might make a very simple additional field in the facility data system, which would actually capture some simple parameter, but that simple parameter will allow you to measure things better going forward. And again, the routine data, a lot of times actually has to be supplemented with at least some interviews or something unstructured to understand what's going on. I'm going to stop now. I'm sorry. I spent exactly 1 hour, so I'm hoping that you guys can stay for a few more questions. We can definitely go a little bit over. I'm sorry, everybody, that I ran over. Okay, I'm going to take a little pause here and take a look at some of the questions that we received. Okay, so let me take a look at so there's a few questions. So one question that I see is an interesting question. Well, all of the questions are interesting, but I think it's what type of design addresses the cost of inaction? So I would say that for the cost of inaction, the best design will be for you to use the cost utility analysis, because remember that we are talking about this burden of disease. And so if you didn't do something, you increase the burden of disease, and that's your cost of inaction, again, in a slightly simplified form, but that would probably be the best kind of the design that would lend uh, to this question the best. So another interesting question, in such cost evaluation study, which method is desirable? Collect data on sample or collect data about the whole project? I think this is this is actually a good question. And I think that it really depends on your, it largely depends on your resources, right, available, because sometimes you just can't go to every facility where you are providing services or to every cost center that exists there. But I think the decision here is really about this heterogeneity. If your program is quite homogeneous, right? So you might have 15 facilities where you're implementing something, or 15 villages where you're providing some sort of awareness campaigns. But whatever you're doing is really say it's similar, right? It's similar. You can go with a sample. And that's going to give you a good idea. You might still need a little bit of contextual information, but you will get a pretty good idea. If you have, at least intuitively or based on what you know about implementation, have some suspicions that those cost structures will be quite different, and the cost in one facility will be quite different than in another facility, then you really probably cannot get away with a very small sample, or you have to choose very, very carefully in terms of where you're collecting this data. Let me take a look at at a few other questions here. Okay, so this is the one that there's a question here that I didn't have huge amount of time to go over, is I would like to know approaches for determining the level of effort of staff involved in an intervention using routine data. Okay, so that is the piece where you really are kind of this is where we are a little bit in a tough place. If it is a program where all the staff are, supporting one thing, right? So it's something standalone, and you hired 3 people to do this program, and these people are working 100% supporting your program. You really don't need to worry about the level of effort. That's rarely true, as you all know, and you can make sometimes you can impute. Again, you have to be quite careful about it. But for example, you might say, well, they are supporting this, they're spending 50% on this program and then 50% on that other program, but they're doing about the same thing. And I know how many patients they have in this program, and I know how many patients that they have in that program. So I'm just going to kind of allocate costs based on the number of patients that they're seeing. You can do something like that. Again, it is limited because you can do it, but in kind of rare situations. Largely to assess personnel costs correctly, especially if they're not doing only one thing, if they're supporting multiple programs, or if what they're doing is important. You really need to have some sort of a little personnel questionnaire. This doesn't have to be some sort of a big survey. You're not going to get exact data for you're not going to be going to every nurse in the facility and saying, okay, how many minutes do you spend on this and how many hours do you spend on that? And you can get a pretty good general idea of what the typical day or typical week looks like through a couple of hours of interviews with a head nurse in the facility, or somebody who is actually in your program knows what people are doing. and get a pretty good estimate out of that. Doesn't have to be complex data collection, but it's very, very often the thing that you do need to do because you can't allocate those costs well just using routine data. So let me take a look how many on other questions. So, okay, here's an interesting question again. If a program is implemented jointly with the government counterpart, such costs like health worker salaries, building costs, and some other may be covered by the national budget rather than the program budget. In such scenario, what would be your guidance to calculate unit costs? So this is a very good question. And I want to remind kind of back where that slide is when I was talking about the perspective, right? So here is who is the person who is asking about the costs, right? And what is important. So here, if it's just the funder that wants to know what the costs are and what the costs to the funder are, then you only have to really worry about those items or resources for which the funder is paying. You don't have to worry about all these other things. So you are in some sense doing analysis from the perspective of the funder, not from the perspective of the program itself, because the perspective of the program will require you to actually go and count up the salaries of the national staff and building costs and all this other stuff. So that's, again, this is your research question, and what is the action that is following from this kind of research that is necessary. Let me say, well, we still have quite a few folks online, so I'm gonna continue with some of the questions. Okay. So what are the types of sensitivity analysis recommended for a program cost analysis? So this is something, it really depends, right? But I think the important things here is price levels, right? Because especially if you're getting those resource costs, unit costs for various things from different places, those things might be changing. Those things might depend. In one region, your unit costs of one thing might be very, very different, but you didn't have a large enough study to actually go and measure it. So this is something that you need to probably consider. The other things for the sensitivity analysis, again, it depends also how large your sample is and what you can do from the statistical perspective as well. But the things that need to be considered is, for example, some of the capacity issues. You might have a hospital and it has a lot of patients. So your personnel is busy, running around, non-stopping. And, so when you take the personnel cost divided by the number of patients they provided services, that cost will be potentially lower than if you have a very rural site where you still need to have a full-time nurse to sit there and see patients, but you only have 2 patients coming per day. And that's, some of those efficiencies or inefficiencies has been resolved over time, but you still might have a situation like that. So and you might have the same types of issues with lab testing, for example. Is the machine that in the lab running at full capacity all the time, or we have the machine, we're using electricity, but we're only running 3 samples at a time because we don't have. So some of those capacity issues might also need to be considered in the sensitivity analysis, especially if you are trying to make decisions about scale up. Next, going to look. I see some questions about modeling and measurements of effect sizes. I'm sorry, I'm not going to answer those questions. I think this is a question perhaps to Jessica, or that's something that okay. So I see another question. Can the economic evaluation be assessed through qualitative assessment? So the answer here is yes and no. you cannot just use qualitative assessment to really do economic evaluations. However, there are components of economic evaluation that might have to include a more qualitative type of assessment. And that is, so we do a lot, for example, again, we do quite a lot of key informant interviews just to understand what is happening, what the flows are, and things like that. So a lot of the interviews that we do when we go to do data collection, we're not going there with like a structured questionnaire. It's a discussion. We are trying to understand how those resources flows, what affects things, who is doing what. So it's really much more a qualitative type assessment. And then qualitative assessments are also often used in those other parts of the cost effectiveness and cost benefit and cost utility analysis, because some of those effects and the impacts to correctly measure them actually involves some level of qualitative assessment. Um, so let me see. Um, So another comment here, this is quite labor intensive costing exercise, but could provide valuable inputs and experience towards eventually establishing health financing system. Do you agree? And is this a reasonable assumption? Yes, I agree. And it's a reasonable assumption. So the one thing I do want to note is that today I kind of showed some of the really complicated scenarios. So I was not trying to scare people, but I was trying to be kind of realistic that if you really need the detail, this is what you need to do. So not every cost study is going to be as messy and as complicated as I was showing today. So I just wanted to have kind of the expectations really low. But it is something that needs to be done, especially when, considering kind of universal healthcare discussions, health financing systems, user fees, all that time. If you, again, think about, user fee elimination. If you're going to eliminate the user fees, and the user fees are paying partially, potentially, the part of the salaries in the facility, where is this money going to come from, and how much is it actually is, and how much do you actually need to give? So these types of studies do need to be done. It can be a time-intensive exercise. There are some kind of shortcuts and certain things that you can do to balance the rigor with the practicality to still get a response to your question, which is going to give you a good enough estimate, but maybe not, a perfectly precise number to the hundredth, to the hundredth decimal or some point or something like that. So let me see. Cost benefit analysis. So cost benefit analysis, in essence, some benefits could be realized after and for a very long time. What is the best economic model available? It is a very good question, but what I'm going to say is that the best economic model will really depend on what your intervention is. So there are existing models that exist with a lot of assumptions and parameterization that has already been done. But it will be a different model if you're looking at HIV versus if you're looking at nutrition versus if you're looking at immunization. So it really has to match your intervention and the assumptions of your program. Sorry, I'm reading the question, so sorry for my pauses.
How about we pick just one more, Anya?
Okay.
Is that okay?
The last question, let me see. I'm sorry. I know there's a lot of questions about converting the benefits and measuring benefits. This is really a complicated topic, and it cannot be answered in 30 seconds. So this is another webinar, has to be another webinar on that for all the guys that are so interested. Okay, if a program is funding multiple interventions across different diseases, what would be some practical approaches for allocating significant indirect costs, management costs not directly attributable to the intervention? Should the approach be based on the, on the percent of inputs or outputs? This is a very good question, but I think that, okay. Here's how I'm going to answer that question. It depends how you're planning to use this information, really. But if you have, if the management costs really don't differ too much, depending on your disease, right? So largely, let's say you're supporting, I don't know, immunization and nutrition. And your immunization is 70% of the cost and the funding, and your nutrition is 30% of funding. If the management costs are really not very different proportionately, then I think that using the percent of inputs will be fine. So you pretty much allocate proportionately to the rest of your funding. If those differ, then you have to go into kind of more complicated things. Outputs cannot, it depends how you measure outputs, because the outputs potentially for your nutrition program and for your immunization program are going to be very different. So again, I think that it's probably the most practical way is to allocate it according to the direct costs. But perhaps some adjustments have to be done just based on the time, on actually what goes into those management costs and how complex it is to manage one disease versus the other disease. I'm sorry, I know this is a little bit maybe less detailed than you might have wanted, but then I'm happy to connect offline for that. Okay, so this was the last question. And I really hope, and thank you guys for sticking for so long. I hope that you enjoyed it, and hope at least that maybe you learned something, maybe not enjoyed. So thank you so much, and thank you, Jessica and others at UNC for making this so perfectly organized.
Yes, thank you, Anya. That was excellent, and lots of interesting questions. You can tell that there's a great deal of interest in the topic. So we really appreciate your time and putting this together and being with us. And a lot of people are commenting on, they appreciate the details that you shared. So kudos to you on many levels. And we will be sharing a link to the slides and the recording of the webinar to everyone registered for the webinar. So you will be hearing more from us very soon. Thanks to everyone, and have a good rest of your day or evening.